What's your opinion on it? Will these make a difference, or should you just wait for our own endogenous production of SPM?
No, I think, especially with the Western diet being the way it is, that we need to intervene, and we need to intervene both at the substrate level by providing EPA and DHA, and not just EPA and DHA, it's a general concept. We need to better understand what these supplements contain, because as you mentioned earlier, as was mentioned earlier, you can go over the counter and buy low amounts of EPA and DHA, and you can't really tell whether these are in a triglyceride form, in a phospholipid form, in an ethyl ester form, in a free acid form, and that makes a big difference in terms of biological activity. And also, when it comes to that, so that would be important just as a therapeutic intervention on a daily basis. When it comes to treating patients, there is evidence in preclinical models that these mediators are actually active orally too, not just systemically, but via oral routes of administration. So if we want to acutely treat patients with mediators to stop the inflammatory response, to start this process of healing, and then maybe even come back with supplementation of EPA and DHA to help the endogenous programs too, to make more of these mediators. I think this is really where we should really be heading.
There's a phenomenon going on right now at this meeting about immunonutrition in general. And that is, for years, we've been very interested in the physiologic response to these immune modulating agents. They sound good. Fish oil sounds the best. You can hardly think of a patient that wouldn't or shouldn't respond to fish oil. And if these resolvins are the active ingredient, we should expect even more out of them. And yet what's happening at this meeting is, when you look at outcome data, we're having to back off a little bit. There are areas where they made sense physiologically, but when you get down to the outcome data, it doesn't drive the routine use. So one of the issues we have on the table is we think this resolvent is going to give us bigger bang for our buck, but are we going to see the appropriate outcome benefits that we would expect?
Yeah, I mean, I think I agree in the fact that, at least in the critical care world, we've spent a lot of time trying to muck up inflammation, for lack of a better way of saying it, stop it or do that sort of thing. And largely we've been unsuccessful, whether that's with, steroids or fish oils or whatever. I think people are receptive to the idea of helping the body modulate their own inflammation, like reestablishing a homeostasis, as opposed to just trying to figure out what we think is overactive and just hammer that. And I think resolvins and SPMs have a potential role there, and I think people are receptive to it.
Well, these agents sound ideal for pancreatitis because of the SAPE hypothesis, the sentinel acute pancreatitis event. There's a trigger, like a gallstone or a drug or alcohol, and it sets up this vicious cycle of inflammation. Right. And you either shut that off and the gland goes back to normal, or you fail to shut it off and it continues to recruit stellate cells and fibrosis, and you go right on to a continuing path of inflammation and chronic pancreatitis.
There is experimental data both in pancreatitis and also in kidney, actually, in ischemic perfusion of the kidney, showing that these mediators are protective in experimental pancreatitis, and they prevent fibrosis, which is really impressive. There's very little to no fibrosis in these organs after, again, experimental models, but it's promising.
The data that I was quite amazed with was the abscess data in the periodontal area, where there is a chronic inflammatory condition in the root of the tooth causing bone loss. Right. And then when they inject the resolvins there, you actually get regeneration of bone and clearance of the chronic periodontitis.
Yeah. The periodontitis is a very interesting condition, because for a long time many people didn't appreciate that it is really an inflammatory, a dysregulated inflammatory response that leads to that general bone loss. And now there's more appreciation of links between periodontitis and cardiovascular disease and other conditions. And the regulation of these pathways, and we've tried it in different scenarios. We've actually used a rabbit overexpressing model, where the enzyme that leads to the biosynthesis of these mediators was overexpressed, and you see clearance of the periodontitis
So
in
you
a
have
ligature model
yeah.
that there's very little inflammation, there's very little bone loss, and when you then have the other scenario where you induce the inflammation, and we've now done it even in the mini pig, which is not as mini as as the name would give.
Yeah. 70 kilograms.
Right.
Yeah.
The bone regeneration is amazing. You know, you have pockets that are up to a centimeter high, deep in bone loss, and you can, within a few weeks, the bone comes back, the inflammation goes away.
Another situation, I'm sitting here thinking, every day on the wards we deal with hepatitis. And now when a patient comes into the hospital with abnormal liver enzymes, they've got some active inflammatory process going on in the liver. Sometimes most of the time we can figure out what's generating it, sometimes we can't. But we give non-specific agents to help deal with the inflammation. N-acetylcysteine is one, zinc because of its effect on antioxidant defense, and Trentol, which is just an anti-TNF. And all we're trying to do is shut down the inflammation before it destroys the liver. And this just, I'm starting to dream about some of the applications.
Yeah. You know, cardiac disease affects 25 to 30% of the population in the United States, probably 40% of the males, maybe 20% of the females. What's our use in that area? Chronic atherosclerotic disease.
So there's actually a lot of data that has been produced over the years, both by our lab in collaboration with a number of groups, to show that these mediators are important in stabilization of the plaque by regulating different components, the macrophage responses, which are known to be very important in atherosclerotic lesions, as well as platelet function, reducing platelet aggregation and coagulation at these sites, as well as the general inflammatory response, especially when you think about things like ischemia perfusion injury or other injuries to the vascular wall, where you improve vascular tone and also prevent injury to the site and clearance of necrotic cells.
Do you see resorption of an atherosclerotic plaque at all? Regression of a plaque?
In data and results that have been published so far, no. There's more stabilization.
Stabilization, non-progression.
But none of the experiments that have been conducted so far have actually really targeted that to really look deeply, because a lot of these models are very lengthy.
Sure.
So obviously, for obvious reasons, people tend to do the first side of it and not the second side of it. But I'm sure that in the future there's going to be more work done in that aspect, because it is an important field, and that is an important area to see whether there's just stabilization, whether actually you can remove the plaque. And my guess is that can be the case. I'm not saying that it completely resolves. We definitely can remove a lot of the plaque, because ultimately the macrophage is an important component there, and we know that these mediators regulate macrophage responses.